Good evening, everybody. It's a great honor to be here speaking to you tonight. Thank you very much, Priyan, for the invitation. It's great to have met you back in Taiwan last year, and hope we can share our knowledge further on. So I was invited to talk a little about overactive bladder, the management, and talk about neuromodulation, which is something we do a lot here in Brazil. So as we know, treatment of voiding dysfunction starts with urotherapy. And we have two types of urotherapy, which is standard urotherapy and specific interventions. Standard urotherapy stands for information and demystification, instructions, lifestyle advices, registrations of symptoms like in diaries, like voiding diaries, and support and encouragement to the child and the family. And the specific interventions are mostly biofeedback, neuromodulation, intermittent catheterization, psychotherapy. So we're going to talk about one specific intervention in neurotherapy, which is neuromodulation. So in standard therapy, if you use it for voiding postponement, we have a success rate in about 55% of the children. But for classic OAB, it does not really work. So we should go forward to the specific interventions. So as you know, neuromodulation can be done mostly in the parasacral region around L2 to L1, and also in the tibial tens, which is the pre-tibial nerve. But this one, we can, the distance from the site of the intervention to the main nervous system, it's further. So supposedly it would work a little worse. But let's go on and talk a little bit about all those. So what's the influences and what's important when you talk about neuromodulation? Is the distance to the target between the stimulation and the target, a tissue resistance. So if you have like fat people or more tissue around it, it's going to be more difficult to the signal to get to the nerve. The frequency of the current, also its intensity, and the type of neurofiber you're trying to stimulate. So the length of the axon and if the fiber is myelinated or not, it also influences in the results. So we can see here in this video how it works. So we stimulate here in the parasacral region between S2 and S4. The signal goes all the way to the brain, comes back and goes to the bladder. So the signal actually is processed in the brain, and I'm going to show you a little bit more about this. So in this study we did back in 2019, while I was as a visiting professor at Yale, we did magnetic resonance imaging in children, in adults actually. It was a group of volunteers and normal people, and we put them in the MRI machine and stimulated them with the parasacral tens. And what we found was an increased connectivity between the anterior cingulate gyrus and the dorsolateral prefrontal cortex. So proving that TENS works mostly in the brain. As you can see in the image here, you see the difference where it works better. So the first studies with parasacral TENS were done by Piet Hoback in Belgium back in the 2001. And he used like 2 hours a day for 6 months. Was a bothersome procedure, but he got 87% improvement in his group. Another group from Bauer at the same time actually usually 1 to 2 hours a day, up to 5 months. But in 2006, Dr. Birajara Barroso here in Brazil, he started doing like three times a week sessions for 20 minutes only, and also got similar results. So, so what we do now here in our group is this protocol of 3 times a week, 20-minute sessions, about 20 sessions. So this is probably the first randomized trial comparing paracyclotrans with placebo. Was done also from the group of Salvador, Bahia. And what they did, they got 37 children, did 20 sections 3 times a week for 20 minutes. And he got improvement in the number of voids, which reduced it. The average void volume also increased, as well as the maximum voided volume. So they showed that the group that were stimulating the parasacral region did better than the group that were stimulated in the scapular region, as you can see in the picture, which is a sham group or a placebo tense that we say. In this other study that we participated, we compared paracyclotrans with oxybutynin, and although the number of children were small, so we didn't see any difference in DVSS score, but TENS was better for constipation than oxybutynin, of course, because anticholinergics increases constipation. We had none side effects when you did TENS. And when you see the results, although there's no statistical difference, we got like a double number of patients and percentage with complete resolution compared to the anticholinergic groups. But I think in my opinion, the small number of children, there was not enough power to see the difference. But families were more satisfied with TENS than with oxybutynin. And there's a study from Spain. They also compared TENS with oxybutynin. This is a newer study from 2021. And they showed a better result with the group that they used TENS, is the blue one in the graphic, when comparing to those using oxybutynin. And they had better voiding, they improved voiding frequencies, mean void volume, and DVISS score, but they saw no difference in the maximal voided volume. So it seems like TENS is better than oxybutynin. We only have few studies compared both, but in this study we see this better improved with TENS. This is another study comparing TENS with oxybutynin. And this study, they did TENS and added oxybutynin to TENS, and also in one group of TENS and placebo oxybutynin, and the other group was placebo TENS and active oxybutynin. And what we saw was a better result when we had both together. So in those children with OAB and that are resistant to treatment, maybe adding TENS and oxybutynin together, we can get better results. Another study from the group of Brazil in Salvador showed that as more sections are done, better results can be seen. So we see the number of sections in the line below, and after 20 sections, we can see a better results. And we see that the results are improving along treatment. Some things were studied to check the predictors of outcome in children and adolescents with overactive bladder. And what we saw was that sex, age, history of UTI, daytime incontinence, frequency, nocturia, holding maneuver, constipation has no predictor of improvement. But children that had also enuresis were less likely to improve the OAB symptoms than those without nocturnal enuresis. Therefore, nocturnal enuresis is a single factor associated as a predictor of improvement. This study was from our group. So one question is the number of sessions should be done. As I told you earlier in this talk, it started in 2001 with 2-hour sessions every day. And now we did a study back in 2017, and we showed that one session a week is better than only urotherapy. So if we add urotherapy and, urotherapy, standard urotherapy plus TENS, parasacral TENS, that's what we did, compared to placebo TENS plus standard urotherapy, we had improvement in urgency, also symptoms of enuresis. And the visual analog scale answered by the parents were also better when we have the group of TENS. Therefore, one session a week, it's worth it. And now we're finishing a study, and this is the preliminary data that we compare one session versus 3 sessions per week. It's a non-inferiority trial. We have already 22 children, and what see that urinary incontinence, and there's no difference. Constipation, there's no difference comparing and also when urgency at the end of treatment, when you compare both groups, also there were no difference, showing that one session a week for 20 minutes is as good as 3 sessions per week. Also in this study, we checked on voiding frequencies. It also was the same, although a little bit better in the group that received 3 sessions, but was not statistically significant. Mean voided volume, maximum voided volume, and number of dry nights in those that presented also enuresis were not statistically different. Once again, 1 session and 3 sessions seems to be similar. Another study comparing now 2 sessions to 3 sessions. This study was done again for the group of Salvador. And what we see was the similar results, that both 2 sessions or 3 sessions a week are similar. So we don't have to bring the kid 3 times to the office. We do usually do off neuromodulation, not at home. And one reason for that is that we think that the contact with the urotherapist, it's importantly improving the results, because there's also a reinforcement of the standard urotherapy. And when the child does the neuromodulation at home, it probably doesn't go all the way up because childs with the parents, they tend to become more, I don't know the word in English, but anyway, they tend not to they, how can I say it? They feel a little bit more pain, and so they ask to do it a little lower intensity. And at the office, it tends to be more, you can go in the intensity a little harder, and maybe this is one of the reasons, I'm not sure. So this is one study that we are starting to do now, comparing home neuromodulation to office neuromodulation, and see how it goes, see if there's any difference, and also see which one is better and if you can do any of it, any one of it. There's one systematic review was published 2 years ago that they got only 8 randomized trials on neuromodulation for overactive bladder, and in conclusion, they found that TENS had a remarkable effect on the improvement of urodynamic indexes and the objective OAB symptoms, without a significant increase in pain and discomfort for child with OAB. So therefore, this reinforced all that we've been doing for a while, that TENS is a good treatment for children with OAB. But there's still a lot to be learned. So in conclusion, what we can say that overactive bladder with the voiding postponement, urotherapy, you can get good result in most of the child, but if you don't, you can use TENS. But if you have the genuine overactive bladder, so TENS may be the first line treatment with anticholinergics also, but in my opinion, if you can do TENS, I prefer. In those that does not respond to either TENS, anticholinergic, or both together, you can use botulinum toxin. So there's still a lot that we need to learn about neuromodulation. We don't know if which frequency is better. If you increase a lot of the frequency, you can get better results or not. If intensity makes a big difference or not. If home or office, which one is better, we still don't know. So there's a lot to learn and study still in neuromodulation. But what we stand now is that neuromodulation is my treatment of choice for children with OAB. And if those that fails or does not get complete response, we can add anticholinergic and we can improve results. So I hope we enjoy. Thanks again for the invitation. It's great honor for me. Too bad I'm not in India. I wish I could have gone there and meet you all and share our experience. But I'm sure we have an opportunity sometimes. And maybe you can come to Brazil. We are gonna host the ICCX meeting 2023. It's gonna be in Salvador, Bahia, which is an amazing city. One of the nicest and most beautiful cities in Brazil. It's gonna be at the end of the year, November 16 to 18. And it's gonna be just before the Brazilian Congress of Urology that starts on the 18th. So both meetings will be almost together. So you are all invited to join us here at the end of the year. Okay, thank you very much.